It's a pleasure to welcome Jingsong Zhang, who many of you are aware, or maybe you don't know, but he was the one that was brave enough to actually allow us to implement an evolutionary trial in prostate cancer. But not only has he allowed us to do it once, he's allowed us to do it many times, and he's going to tell us about all the ongoing trials and opportunities. So thanks, Jingsong.
Thanks, Andy. So I'm a clinician, so I won't talk more about the models. It's basically a quick overview of the biology of prostate cancer to help you understand, why the model may work in this disease, the unmet need, and the potential impact of our adaptive therapy approach. So prostate cancer is very common. So this is a JAMA paper. They estimate between 2020 and 2040, the global incidence of prostate cancer will double to up to 2.9 million. When more people diagnosed with prostate cancer, there were expected more patient deaths as well, globally as well as in the United States. That's in the setting of, 10 different drugs approved in the past 5 years to prolong survival of metastatic prostate cancer. So, 1963, Dr. Higgins won the Nobel Prize for discovery of androgen deprivation to treat prostate cancer, but it's not clearly understand why blocking testosterone can treat prostate cancer until 2005. An MD PhD student working at Dr. Chinayan's lab, University of Michigan, found out this TMPRSS ERG fusion. Essentially, TMPRSS is downstream of the AR pathway. ERG is a proliferation transcription factor. So with this fusion gene, essentially the cancer cells, they hijack the testosterone, which is supposed to be a male hormone. Now they drive the cell proliferation. So up to 60% prostate cancer have this fusion. The majority of the rest has the SPOT mutation. Again, it's an AR-driven proliferation pathway. But if you make a transgenic mouse with TMPRSS ERG, the mice that actually do not develop prostate cancer. At the most, they develop some precancer lesion called high-grade pain. But if you cross the mice with loss of PTEN mice, then they will develop prostate cancer. So loss of PTEN, particularly enriched in the later phase prostate cancer, up to 40%. And about 25% of prostate cancer carry a mutation in homologous DNA double-strand repair, the represented one was the BRCA2, BRCA1, ATM, TRK2. Then with treatment, the cancer can mutate, have AR mutation. And then a subset of prostate cancer, when they have even other diagnosis, TP53 mutation, loss RB, those are the genes involving cell cycle regulation. So those are the cancer has a high risk to become androgen independent, and then we call neuroendocrine transformation. So that's the most aggressive type of prostate cancer. And Dr. Gleason in the 1970s come up with this Gleason score. If you think about it, this is actually the first time we know how to grade tumor heterogeneity. So it's a sum of two patterns. So the first score is the most dominant pattern. If the cancer doesn't look like a prostate gland at all, you have a score of 5. So 5 doesn't look like prostate gland. They also tend not to make PSA. So the most aggressive type of prostate cancer are the low PSA producers. So sometimes we see patient PSA up to, I have patient diagnosis PSA more than 5,000, but they respond very well to androgen deprivation, drop to less than 1 in 3 months. It's the patient who develop, metastatic disease with PSA less than 10 or 5. Those are the cancers that are most aggressive and harder to treat. So up to date, the androgen deprivation is still kind of the cornerstone of prostate cancer treatment. So if you look at the RHR analog, we have 5 drugs. In green is an antagonist, and then the white is the old school agonist. So those are the class of medication. Down here is an AR antagonist. So this kind of second generation, old generation bacalautamide, second generation Anza, APA, and the darolutamide. We also have abiraterone, which is a CYP17 inhibitor, which blocks the production of testosterone by the cancer cells, as well as the adrenal gland. So unlike prostate cancer, unlike breast cancer, you have the hormone receptor positive one, triple negative ones. Prostate adenocarcinoma, 100% is AR driven. The initial response to ADT is also 100% response rate. But the depth of a response, or duration of response, really separate them out in terms of prognosis. So, here's the 6 phase 3 trials look at for newly diagnosed metastatic prostate cancer, combined androgen deprivation essentially use the LHRH analog plus one of the AR pathway inhibitor, either AR antagonist or the CYP17 inhibitor with abiraterone. You can appreciate the curve looks very similar, so this is the one actually unique. So this study is the only negative study. So all the other 5 trials shows improved survival when you early utilization of AR pathway inhibitor. So this study is actually, this is the study done in United States only. So all the other study, 80% patient, enrolled outside the US, there are always questions about access to subsequent treatment. The other thing about the SWOG study is open label. So they switch early, they allow patients to switch treatment even with at the site of PSA progression. So lots of other trials, people are not allowed to switch active treatment until imaging progression. And the SWOG study is also with active control, use bicalutamide instead of placebo plus ADT. And then, more is not necessarily better. So, but you can, in theory, combine CYP17 inhibitor block the testosterone production with AR antagonist block the testosterone action. That's in theory may be better, but the trial shows if you combine abiraterone CYP17 inhibitor with AR antagonist and enzalutamide, you don't really improve overall survival. The curve stays about the same. So I think the question always comes to mind when we face a patient, how to re-stratify. Nowadays, lots of people get overtreated for prostate cancer. Part of the reason is because the PET scan. So the PET scan, the PSMA PET, so prostate cancer doesn't take up sugar, so we don't really use the FDG PET to stage prostate cancer. They do have a specific tumor antigen called PSMA. So there are 3 PET tracers to early detect prostate cancer metastasis. So nowadays we see lots of people in the clinic, with sub-centimeter lymph node, but they have a PET uptake up to 20 or 30. We know those are early metastases. They are being treated as stage 4 disease. But this group of patients were never included in any of the phase 3 trials. For clinical trial enrollment, there's criteria, you have to have a measurable lesion, then you can reliable to assess response. So for measurable lesion, the lymph node has to be at least 1.5 centimeter. So, there are about 30% patients with metastatic prostate cancer nowadays. It's just PET positive disease, negative on conventional scan. So this is an image. This is a patient with more advanced prostate cancer. You can see, the kidney, the urine, the ureter light up, the parotid gland. This is all physiological uptake. There's a liver metastasis that's a little bit up above the background, and then there's some bony metastasis. So in terms of prognosis, prostate cancer, the best prognostic factor is the PSA response, 6 to 7 months into a treatment. If you can bring down the PSA to less than 0.2, on the left-hand side, this is the SWOG 9346 study, essentially starting in 1993. If you focus on the blue curve, so those are before we have enzalutamide, also the new treatment, all we got is chemotherapy, bicalutamide. But if you drop PSA less than 0.2, even in the old days, their median survival is more than 6 years. So this similar finding was confirmed by 5 additional phase 3 trials. So essentially the PSA response is the best indicator in terms of prognosis. And also we have this definition of high volume disease as well as a high risk disease, particularly high volume disease. It is being used in the clinical setting to decide, which patient will need treatment intensification. Again, this is just show kind of the curve. If you compare to the upper left hand for SWOG study, when people do have rapid PSA response, even with old school treatment, if you focus on that blue curve, the curve looks very similar to the other 3 trials when they use more potent AR pathway inhibitor. The bottom one is actually a triple therapy. They also combine chemotherapy. So for subset of patients that you don't really need treatment intensification. So this data was just presented at ESMO meeting 2 weeks ago. This is a long-term follow-up. You can see they have like 10 years of follow-up. Most phase 3 trials, they stop overall survival after follow-up after 5 years. The interesting thing part is here. You can see the curve crossover. Sorry. So this is about 5 years. So the orange line is treatment intensification with AR pathway inhibitor. You can see the survival is better, but with time, just the monotherapy appear to be the winner. If you break it down further, the disease volume does matter, particularly for low volume disease. You don't have to use the treatment intensification. So I think lots of times when we do phase 3 trial, those studies are very expensive. At the most, they will start follow-up after 5 years. But this is a real-world data, so basically treated in the Europe, they do a longer follow-up. So those are the things, it's reassuring for the approach we are taking in terms of, how to select patient, how to optimize, the treatment for metastatic prostate cancer. I think like the other speaker says, every patient deserves an equation. So just brief overview of this is therapy. So the idea of on and off treatment is not, kind of a strange thing for prostate cancer patients. Back to the 80s, people started to do intermittent therapy approach. It mainly, androgen deprivation is essentially chemical castration. So most patients hate it. So they try to see whether they can take some treatment breaks. So the left-hand side is the PR7 trial. It's for patients with biochemical recurrence, essentially only PSA recurrence without metastasis on the conventional scans. There's no difference in overall survival. The SWOG study was done in 1993 and reported, both papers reported in 2013. So after about 20 years of after the study started. The initial design of the SWOG study is non-inferiority to show the intermittent therapy, but they do, statistically it's inconclusive to show non-inferiority, but there appear to be a difference. The people on the continuous treatment arm does appear to live longer. So just a quick overview of the design of the SWOG study. So everybody start with a very long induction phase, 7 months of induction phase. And then they have to show this is a castration-sensitive disease with PSA less than 4 before they got randomized. So people on the intermittent treatment arm, they go back on the treatment, either PSA increase to 20 or increase to their pre-treatment baseline if it's less than 20, or at the discretion of the treating physicians, they can go back on treatment 10. But when they go back on treatment, they will on treatment for 7 months. At the month 6 and 7, the PSA has to be both less than 4 before they take another break. The other, I think, interesting design of this study is if on patient on the break, if there's PSA progression within 3 months, then they will basically cross over to the continuous treatment arm. Essentially, that's for androgen deprivation, 7 months of treatment, most men will take at least average 9 months, sometimes more than a year, to recover the testosterone. So in the first 3 months, most patients, the testosterone is still less than 50 in the castrate level. So when they have PSA progression indicating that they progress into the castration resistant stage, that's the reason they cross over to the continuous arm. So there are lots of room for improvement for the study. I think one thing is they on the treatment for too long, and also everybody is kind of follow the same on and off treatment regimen, which is convenient for phase 3 large study, but may not be ideal for patients. But this kind of design is copied over even in the most recent phase 3 trial. So this is again presented 2 weeks ago at the ESMO meeting. This is a large randomized phase 3 study in Europe, look at intermittent therapy. So very similar to the SWOG study. The only difference is instead of bicalutamide, now you have more potent AR pathway antagonists like enzalutamide, apalutamide. So our approach, we start look at the tumor heterogeneity, more look at the dependence on the testosterone signaling. So we, when we stain the prostate cancer cells for testosterone androgen receptor, which is the basically if they have active AR pathway, you will have a positive nuclear stain. And then we stain for the CYP17, which is a membrane protein, is the basically target of the abiraterone. So you can appreciate the heterogeneity even in the untreated primary tumor and the primary tumor lymph node metastasis that's shown in panel B there. And then the top graph is basically, we have a commercial tissue microarray, look at this different population. The TP is the AR positive, CYP17 positive cells that they can produce testosterone. T minus essentially they stain double negative. T plus is the ones that depend on testosterone. They stay negative for CYP17 but positive for AR. So, initial modeling was done by Jessica Cummings with help of Bob Gatenby and Joe Brown with the game theory model. So we see the on and off approach would be ideal to manage this tumor heterogeneity. So this is the first study in the castrate-resistant prostate cancer. In this study, everybody stay on the androgen deprivation. We just look at on and off treatment of abiraterone. So the blue is kind of match historical control. The red line is the patient treated with the adaptive approach. So this study, we started in 2013, and the first paper was published 2017. Now with longer follow-up, there's still 2 patients alive on this study. Again, this approach appeared to be feasible and also prolong the duration of response, delay the radiographic progression-free survival. So with the paradigm prostate cancer changing, abiraterone, all the other drugs, just like I showed in the slides with the 6 phase 3 randomized trials, now it's more utilized in the castrate-sensitive setting. So our initial thought is maybe do a randomized phase 2 in the castrate-resistant setting because the drug now is move more upfront. So our second study is look at castrate-sensitive setting. In this design, actually, we allow patients to stop ADT as well as the AR pathway inhibitor. When they go back on the treatment, they will based on their testosterone level. If the testosterone level is, just graph here is more than 100, then they just go back to ADT by itself. It's between 50 and 100, then they just start with abiraterone, also called a new hormonal agent, NHA. It's less than 50, they will start both. So this study was published. We actually have long-term follow-up data on this. Most people doing well. So now we have median follow-up about more than 5 years now. We haven't reached the median progression-free survival yet. But even in this group, we include people with high burden disease, high risk disease. There one guy with TP53 mutation. But you can see even in this small subset of 16 patients, there are patients with kind of early progression showing here. So then some people with late progression, ideally you would like this, people can take long breaks and then enjoy this intermittent therapy for a long time before they become castration resistant. Jill is sitting in the audience. She did some modeling based on our initial trials. I think this is an agent-based model. In this paper, Jill essentially showed that in terms of the metastasis, if regardless the metastasis burden, if you have a dominant high volume metastasis, that can drive the initial treatment cycle. When you take a break and recover before retreatment. And also, the intrametastatic heterogeneity respond better to adaptive correlate with a patient with intermediate Gleason score. If you're interested, I put a reference there. For the second study, Jill particularly look at the PSA testosterone ratio that appear to be predict which patient will be doing well with the adaptive therapy approach. For patients like here, in the first on and off treatment cycle, if they have a very high PSA testosterone ratio, they cannot do well as a patient like this. So the blue line is androgen deprivation, and then the purple line is combined treatment. The black line is the treatment break. So based on this, actually, we are conducting our kind of third generation adaptive therapy trial. So again, patient with newly diagnosed metastatic prostate cancer, after good PSA response, they will take a break from both treatment. And then when they go back on the treatment, the unique part of this study, we will base on individuals' PSA dynamic in the first treatment cycle to determine individualized PSA threshold. We call it PSA-BT here. So you can see this is a one sample report on one of the patient, his Gleason score baseline PSA, and then PSA testosterone ratio. In this case, he's considered low risk, would benefit from conventional approach. So his PSA burden threshold is determined at a 50% PSA drop. We have people, they actually stop treatment after 70%, actually 30% PSA drop is because they are more like a high risk. There's high risk for developing resistance. So this study, I'm glad to report, was started this January. So we'll finish enrollment of 25 patients by next month. So this is a market only study, so you can appreciate, this is kind of very enthusiastic about it to get involved. I think we're ready to design a randomized phase 2 trial in this space. I think I'll stop here and open for questions.
Okay, any questions for Jingsong? No? Well, I mean, I guess from my point of view, one of the things is someone who's personally involved, and especially in this third generation, where now the modeling is helping make the decision making. One of the things that's worth pointing out is that Jill is slowly being submerged by a huge amount of patient data, and as these patients accrue more rapidly, you realize what you've committed to, which is, refitting the dynamics of their disease every time they get a new time point. And when you go for 2 patients to 4 to 15 to 25, that starts to add up. So I guess the model of the tale is be careful what you wish for.
Yeah, I think essentially we hope, we can leverage the AI approach to really scale this up. If you do a randomized study, you have to have those kind of a complete computer algorithm with the help of AI. We cannot, overburden Jill for this.
Jingsong, are there other biomarkers in other tumors that you can use to model similar to what you've done in prostate with PSA?
Yeah, so we actually Sandy support a kidney cancer study. Clear cell renal cell is actually the disease much more cleaner than prostate cancer. 80% has the VHR mutation, and then that basically says they are very sensitive to anti-VEGF TKI. But we don't really have a validated biomarker like a PSA to help to make the disease treatment decision. But it's an ongoing study. I saw a poster from Joe Brown's group, look at VEGF modeling. So there's, I think, essentially we are collecting the plasma, we have the imaging data, so that will help us to learn about this disease and how to model it. In melanoma, we also did a adaptive therapy trial using LDH, which is a much better marker for disease burden compared to prostate cancer. But you do need a good marker. So I think I spent lots of time talk about prostate biology, essentially just say, why this model is unique, why the PSA works for this disease.
And obviously, we're going to hear a little bit about ovarian cancer this afternoon, and that's another disease that has a nice systemic biomarker. But the reality is many cancers don't. And we still want to use these approaches. So what's the best way forward for that? We thought ctDNA might be the answer, but we're still very much on the fence on that front because it's kind of messy and noisy, as we've heard from a couple of the talks today. Clinical imaging is definitely an option, but that's so sparse in terms of the decision points. So maybe is there some in between, and what does that look like? So something that food for thought.
Yeah.
Anyway, thanks again, Jingsong. That was very nice.